What's up guys, Jeff from Sorta Healthy here. And today we're going to finish going over ACE material that you should know to pass your exam. To pass your ACE Certified Personal Trainer course, you need to score 70% or higher on a 150 multiple choice question exam. The exam covers a whole bunch of different topics which are relevant to personal training, such as recognizing when a client has high blood pressure, doing physical assessments, calculating calorie counts on nutrition labels, etc. In this part 2 video, we'll continue to cover the material that we started to break down in my last video on passing your ACE exam. We'll also be referencing a study guide in today's video, and you're all free to download that by going to this link located in the video description as well. I'll be using this guide to help me explain most of the concepts that are likely to appear on your exam. That way, when it's time for you to take the big test, you'll be ready. All I ask before we jump into today's material is that you consider liking the video and subscribing to the channel if you haven't done so already. This support is what allows us to make these videos, free guides, and other things like that. I really do appreciate the support, everyone. Let's get back to studying for that ACE exam. Okay, so now we're just jumping right into it. Like I mentioned before, this is a part 2 video, so if you haven't watched part 1 yet, it might be a good idea to go back and watch part 1 first. You could always just start with this part 2 video and then go back to that part 1 video after. Just so we're clear, I am not affiliated with ACE in any way whatsoever, though I am an ACE certified personal trainer. Anyways, the first major thing we'll be talking about in this part 2 video are risk factors for cardiovascular disease, or CVD. This includes things like age, family history, cigarette smoking, blood pressure, etc. For age, if you're a guy who's 45 years or older, that would be considered a risk factor, and for women, if you are 55 or older, that is also considered a risk factor. For family history, if your brother or father had a heart attack, death, or heart surgery before 55, or your mother or sister had one before age 65, that is also a risk factor for CVD. Cigarette smoking, duh, have they smoked within the past 6 months? So that means even if you quit like 3 months ago, technically cigarette smoking would still be a risk factor for you. And a little bit less common, but maybe you're exposed to smoke on a regular basis at work or something like that. Technically, in that case, this could still be a risk factor for you. Blood pressure would be a risk factor if it's greater or equal to 130/80, or if that person is already taking meds to control their blood pressure. If you live a sedentary lifestyle, that is a risk. Not doing moderate intensity physical activity 3 days a week or more for 3 months or more. Obesity is a risk factor if someone has a BMI of 30 or greater, or they have a waist circumference of 35 inches or more in females, or 39 inches or more in males. Next up, we have dyslipidemia, which essentially is bad cholesterol. So LDL is what is known as bad cholesterol, and if your LDL is greater than 130, that will be a risk factor. HDL, high density lipoproteins, that's what's known as good cholesterol. If your HDL is under 40, then that would also be a risk factor. Now, if you don't have these two pieces of information, if TC, or total cholesterol, is over 200, or they're on medication to control their cholesterol, then dyslipidemia would be a risk factor for that person. And last but not least, we have diabetes. If they have type 1 or type 2 diabetes, or even if they have pre-diabetes, this would also be a risk factor. Now, is it worth memorizing all of these things? Risk factors for cardiovascular disease, age, family history, cigarette smoking, blood pressure, etc. And honestly, that's kind of a tricky thing to answer, because when I took my ACE exam just a few months ago, there were quite a few questions that had to do with all of this stuff. So I would either recommend memorizing all of these risk factors, or at the very least, know them well enough so you can pick them up on a multiple choice question. Also, I shouldn't forget that ACE may also consider high stress a risk factor as well. They aren't really clear on it, to be honest. If they're asking you how many risk factors a client has, and they also say that client is under a ton of stress, I would count it as a risk factor. The only way to get a negative risk factor, or to subtract a risk factor from your total amount of risk factors, would be if your HDL, your good cholesterol, is over 60. That would count against all of your other risk factors. So if I smoked cigarettes, I had high blood pressure, but my HDL was over 60, I would only have one risk factor, because my high HDL would cancel out one of those other two risk factors. I know, unfortunately, a lot of this stuff is fairly tedious, and unfortunately, ACE doesn't really do a good job of teaching this portion of the material. That being said, if you have a good understanding of everything that we just talked about, you should be totally fine. So like we mentioned before, we'll talk a little bit more about blood pressure in more detail, and normal blood pressure would be under 120 over under 80. And whenever you're looking at blood pressure, the first number or the top number is systolic and the bottom number is diastolic. Elevated blood pressure would be anything from 120 to 129, and you'd still have to be under 80 with the diastolic number. Next up, you have stage 1 hypertension. Hypertension meaning high blood pressure, and anything from 130 to 139 being the top number, or 80 to 89 being the bottom number, that would put you at stage 1 hypertension. And then stage 2 hypertension is greater or equal to 140 over, again, the systolic number being the top number, over the diastolic number, greater or equal to 90 on the bottom, that bottom number, again, being the diastolic number. So it's very likely that you'll be given a blood pressure on the test, and you'll have to identify what stage that client is in. So yeah, this is one of those rare instances where I'm actually going to tell you these are numbers that are probably worth memorizing. And while we're on the subject, it's common to be asked about two different kinds of blood pressure medications, and those would be beta blockers and diuretics. So beta blockers lower your heart rate at rest and during exercise. And this means a client's heart rate won't raise the same way during exercise when they're on a beta blocker. So if you're asked a question about a client who's walking uphill on a treadmill, but their heart rate just isn't going up, well, most likely that person is on a beta blocker. Next up, we have diuretics, and these increase the excretion of water from the body through the kidneys. And this could increase the likelihood of dehydration, and of course that's relevant to us because we make people sweat for a living. So make sure you guys remember what beta blockers do and what diuretics do. Next up, we'll be talking a little bit more about diabetes, and we'll start with type 1. And these people have to inject insulin. They are insulin dependent, and people usually develop type 1 diabetes very early, either young childhood, sometimes in teenage years as well. There's also type 2 diabetes, and these people are insulin resistant, and this one usually comes down to poor lifestyle choices, and it's far more common than type 1 diabetes. Having either form of diabetes is considered a risk factor, which we're going to scroll right back up there now. Also, pre-diabetes is a risk factor. You guys don't necessarily have to fully understand what pre-diabetes is, but it's something that might be worth looking up in your textbook. You also have other conditions like asthma, osteoporosis, arthritis, metabolic syndrome, etc., and you could be asked questions on any of those. And that's why I say consider reading through chapter 13 to gain a general understanding of all of that material. I would look at exercise recommendations for all of those conditions, but I wouldn't memorize the details. And here's a good example of what I'm talking about, something to look over but to not memorize. And here we're talking about resistance training for people with arthritis. They recommend resistance training 2 to 3 days a week for people with arthritis. Your intensity with these clients should be 50 to 80% of 1 rep max with a low initial intensity. And yeah, the rest of this stuff is pretty much status quo. 2 to 4 sets, 8 to 12 reps, yada, yada, yada. Again, none of this stuff is going to be worth memorizing. Just have a general understanding, and that's why, like we said before, just read through chapter 13, check out all those boxes that they have, pretty much all scattered throughout the chapters. Those do contain valuable information that could be on your test, but the vast majority of the time, they're not worth memorizing. They're just worth looking over. Next up, we'll be talking about assessments, and oftentimes these are featured pretty heavily on that ACE exam. We've already kind of talked about a few assessments, such as blood pressure, which you could take for new clients. Even having your client fill out health history forms like the PAR-Q, for instance, that could even be considered an assessment in its own right. There is considerably more to talk about here, though. For some of the upcoming assessments, you'll need to take a client's pulse. There are 2 spots you should consider while doing this, and those 2 spots are the carotid artery and the radial artery. So the radial artery is on the side of the wrist, just a few inches beneath the thumb, as you can kind of see in this picture right here, which means the carotid artery is on the side of your neck. And this one you really don't want to necessarily use to take a client's pulse during an exercise session or during an assessment because, one, it's just obviously more invasive to touch someone right here. And also if you push too hard right here, you can cause what's called a vasovagal response, which can actually lower the client's heart rate. Anyway, to get a client's heart rate, or BPM, beats per minute, you could take their heart rate for 30 seconds and then multiply that number by 2, or you could just take it for a full 60 seconds. So a normal male, this is resting by the way, heart rate is between 60 and 70 BPM. For females, it's 72 to 80. And if a client's heart rate is 5 beats faster than their typical resting heart rate for a period of days, they may be overtraining, and that would be a reason to ease up on training. I did have an overtraining question on my ACE exam, and it did have to do with a client's heart rate, so make sure to take note of everything that I just said. So sinus tachycardia is a fast but steady resting heart rate that is over 100 BPM. And sinus bradycardia is a slow but steady heart rate that is under 60 BPM. Sinus bradycardia wouldn't be a bad thing at all. In fact, a lot of really healthy, active people will kind of already have this going on. But sinus tachycardia would be a problem. And if you have a client who has a resting heart rate over 100, that would definitely be a reason to refer that person to a doctor. Next up, we'll be talking a little bit about circumference measurements, and there are 5 that ACE recommends. So first we'll talk about the hip circumference, and basically you just measure at the widest portion of someone's butt. That's going to be the circumference measurement that you would take at a person's hips. So next up we have the biceps measurement, and basically it's exactly at the midpoint of the arm here, or the midpoint between the olecranon process, which is your elbow right here, and the acromion, which is your shoulder up here. Next we have what's known as the true waist, and it's the narrowest portion of a person's torso, and it's below the xiphoid process, which this dude's xiphoid process would be right here, and it's above the umbilicus, which the umbilicus is your belly button. So again, the narrowest portion here would be the waist, and that is another measurement that you would take if you're doing an assessment with ACE's materials here. There is also the abdominal measurement, which is literally just right across the belly button here. And last but not least, we have the thigh measurement, which is halfway between the knee and the inguinal crease right here. So basically it's the exact midpoint of the leg. Now, all of what we just went over here falls back into that category of useful to know. You definitely could be asked about it on an exam, but probably not worth memorizing. It's possible you could get a question about waist to hip ratio. I wouldn't bother memorizing what a good hip to waist ratio is, but they could make you calculate something, and all you'd have to do there is divide the waist number by the hip number, which I feel like is pretty obvious because it is waist to hip ratio. Again, referring back to this earlier slide, the only thing that I would memorize here is if a person's waist measurement for females is over 35 inches or 39 inches for males, then that would be a risk factor. So that is something that I would actually memorize here. Anyways, something that's certain to come up at some point on your exam are postural deviations. Basically, you'll be looking at a client's posture. They'll have a few things going on, and you'll have to identify what some of those things are. We have this exaggerated lordotic posture or lumbar lordosis. We're all supposed to have a lordotic curve in our lower backs, but it's a little bit exaggerated here, which can definitely cause some problems. So essentially when we're dealing with a client whose lordotic curve is too great, which we can kind of see in this picture, that lordotic curve's a little too great. We're all supposed to have a small curve there, but not that much. The sentence here is a little bit too redundant, but it is true. The lumbar extensors and the hip flexors, they are too tight and short. On the other hand, your hip extensors, which would be things like your glutes and your hamstrings and your core muscles, well, those are all lengthened and weakened. If my back is too arched like this, well, you can kind of see basically my abdominal muscles are in a constantly stretched out state, and they can't really be too strong from that position. So again, from an exaggerated lordotic curve here, my abs are pretty much going to be weak by default. What also happens here is as this lordotic curve increases, these muscles kind of just get stuck shortened, which is also not good. So they're locked tight and short. And then these hamstring and glute muscles on the opposite side of the body, they're lengthened a little bit too long, and they are tight, so they're tight and over lengthened. So I would definitely make sure to memorize this stuff right here. The hip flexors and lumbar extensors, they're too tight and they're too short when you're dealing with an exaggerated lordotic curve. And your hip extensors, which really are the muscles on the opposite side of the body, the glutes and the hamstrings, they are also tight, but they're tight because they're over lengthened and they're weakened. And again, if we go back up to here, it all makes sense that that would be the case. So make sure you understand, again, which muscles are too tight, which ones are also too tight, but too tight because they're lengthened, and make sure you understand why those muscles are that way. So next up, we're going to be talking about this kyphotic posture. And this one is also super common, just like the lordotic posture. Both of these two are very likely to appear on your exam. Anyway, in this kyphotic posture, the anterior chest, shoulder muscles, lats, and neck extensors are all too tight and shortened. The rhomboids, lower and mid traps, and neck flexors are all lengthened and weak. And of course, if we're looking at someone who has too great of a kyphotic curve, it pretty much looks like this hunchback or this dowager's hump thing. Doesn't really matter what you call it. It goes by many names. Not only is it not the best to look at, but unfortunately it does cause some biomechanical problems oftentimes as well. And I think the easiest way to remember this is basically if I am too kyphotic, kind of like this, well, basically all of the muscles on the front side of my body, which the pecs are the most obvious ones, well, they are too tight and shortened. And you can kind of see that on me right here, right now. Like they're all bunched up right here in my pecs. And the opposite is true of most of those back muscles, like my rhomboids, for instance. The rhomboids, their whole job is to pull my shoulder and my arm back, right? Retraction of the shoulder blade. So if I'm constantly here, well, basically my rhomboids and my lower and mid traps, they're just overstretched this way all the time, and they can't really be strong from that overstretched position. So they are weak and overstretched, whereas my pecs, they are too tight as well, but instead of being overstretched, they're actually kind of just stuck in this shortened position. Definitely make sure you have a good understanding of an overly lordotic posture and an overly kyphotic posture. By the way, these two things can happen at the same time. In fact, they usually do happen at the same time, so also be aware of that. Next up, we have anterior pelvic tilt, and this usually occurs alongside a lordotic posture as well as kyphosis, and it kind of is what I just explained to all of you guys before. So as you can see, this dude's pelvis tilts forward a little bit too much. You can kind of see this angle here, tilting too forward toward his anterior or his front, as opposed to this guy whose pelvis is more or less straight. Anterior pelvic tilt is very, very closely associated with an overly lordotic posture. It's also associated with kyphosis. Again, all of these things oftentimes happen at the same time, but as you can see, this guy's lordotic curve is just, it's way too excessive, and because of that, some of these muscles in his low back are too short and tight. His abdominal muscles are long, taut, and weakened, like we said before. And like we also said before with the lordotic posture, the muscles, his hip flexors on the front side of his leg, they are too short and tight. His hamstrings and his glutes, they're long, taut, and weakened. And a lot of this is just due to poor lifestyle choices. This guy is probably sitting way too much, not moving around nearly enough, and because of that, certain muscles just aren't getting used enough. On that note, at one point during the practice test, I was actually asked which client would most likely experience anterior tilting of the pelvis. And they threw a whole bunch of different answers. For example, one of the answers I think was a nurse who was kind of slouched over for some periods of time, but she was also kind of working and moving around a lot throughout the day. But the correct answer was an accountant who was just sitting for 12-hour shifts, and that's pretty much all he was doing. So make sure you understand why that's the case. There's also forward head posture, and the overactive muscles here are the cervical spine extensors, the upper traps, and the levator scapula. And as you can see, again, this dude's head is just too far forward. So I would actually memorize which muscles are overactive here Yes, that's right. I did say memorize. And as far as underactive muscles go, well, if we go back to kyphosis, again, kyphosis and forward head posture typically happen at the same time, so the underactive muscles are pretty much going to be the same. And you almost certainly will get a question or two where you have to identify what a person has going on posture-wise, so be able to pick out if a person has a lordotic or a kyphotic posture, because they're probably going to give you a person who only has one or the other. You're very unlikely to have to identify someone with sway back or flat back or scoliosis postures. They're likely just going to be thrown in to distract you. So really make sure you understand lordotic and kyphotic postures. Just look these ones over generally in the book, understand them, don't memorize them. And also really make sure that you understand anterior pelvic tilt and forward head posture as well, because both of those things are important and they're very much related to those two postures that we just talked about. Now we're going to start talking about physical assessments. We'll kick things off with a unipedal or unipedal stance test. We're going to go through these physical assessments really fast because honestly you don't really have to know that much about any one of them. It assesses static balance and your client's likelihood of falling. It could also help determine abilities to do tasks of daily living. Basically, a client stands on one leg with eyes open and then they do the same thing again with the eyes closed, and you would time both trials. A test that you'll almost certainly never do, but it's good to know what it is a VO2 max test. In this test, the subject is on a bike or treadmill, and the goal is to determine the maximal amount of oxygen the subject can use and consume during exercise. Next up, we have the dynamic Y-balance test, and I guess you could probably figure this out, but it does in fact test your dynamic balance. It can also help identify differences between the two legs, the right leg and the left leg, which could be useful for preventing future injuries too. In this test, which you can see here, has primarily been used in college settings, so it's probably not appropriate for older individuals or people who have balance issues. Next up, we have the McGill Torso Muscular Endurance Test Battery. And basically here we have 3 different tests that assess muscular endurance of the trunk flexors, the lateral core muscles, and the torso extensor muscles. And these 3 different tests are timed and scored separately. This one is almost certainly going to show up on that test in one form or another. So the main purpose of these 3 different tests is to help evaluate a client's core endurance and stability. And because core endurance and stability is very helpful for preventing low back problems, really just back problems in general, this test can help determine how likely a client is to experience back issues. And this is what all 3 look like. So we have the trunk extensor endurance test. Essentially, it's kind of testing your low back specifically here. Basically, you have one person kind of holding the legs of another, and you have this other person kind of balancing here off of the massage table for an extended period of time, however long that person can go for. We have the trunk flexor endurance test. Kind of almost looks like a boat, and essentially this step here is to catch the person if they can no longer hold themselves up with their core muscles here. And then we have the trunk lateral endurance test, which is basically a side plank, and you could do that with your hips on the ground, or you could do the full version, which Alexis is showing right here. Again, each of these tests is timed and scored separately. This all being said, these tests are contraindicated, or basically just don't do them with clients who already have notable back problems. Make sure to write that last part down. It definitely could come up on the test. Next up, we have the Thomas test, and its purpose is to assess a client's hip flexor length or tightness. Again, hip flexors being these muscles on the front side of the leg right here. Basically, your client is laying on the edge of a table like this, so this would actually be a massage table, pretty similar to what's shown up here, except again, they're laying on it on their back this time. Then basically you have the client flex a leg towards the body until their lower back is flat against the table. And as they're doing that, whether the leg that's not flexing stays glued down to the table or it kind of lifts up into the air like this one is right here, well, basically that tells you how tight that person's hip flexors are. If their hip flexors lift up like this, it means they're pretty tight. And if it stays glued to the table, well, they still could be tight, but they're almost certainly not as tight as, again, this person right here. Of course, there is way more that goes into it than just that. There's a whole scoring system and everything, but we really don't need to know that for this test. We also have the passive straight leg raise, and you can kind of tell by the picture here, but this is to assess the length of a client's hamstrings. We also have the bend and lift assessment, and I don't really know why they feel the need to call it the bend and lift assessment. It's a squat. So basically, you're just watching your client squat from the front and from the side. And you're not correcting form here. You're having a client do 10 reps, again, viewing some of those from the front and some of those from the side. And you're not correcting form because you just want to see how that client naturally moves on their own without correction. In the part 1 video of studying for your ACE exam, we talked about a common pattern that you'll often see lots of clients do when they're squatting. Basically, we talked about a client who, as they're squatting, they're leaning too far forward. And ACE is pretty likely to ask you a question about that client who's squatting and leaning too far forward. Again, to learn more about that, go watch the part 1 video. Another faulty squat pattern they could ask you about is when a client is squatting, but their legs are kind of buckling together like we can see in this picture right here. There's a few things going on here, but if you see this pop up in any form on the test, you know the main reason for this happening is that the adductors are too strong and tight relative to the abductors. Basically, the glutes, mainly glute medius, is too weak in this situation. And this makes sense when you think about it, because the adductors in your leg would be the things that are adding your leg back to your body, and the abductors would be the things that are the muscles that are moving your leg away from the body. So if your adductors are too tight, again, the muscles adding the leg back to the body relative to your abductors, your abductors, well, your knee is just gonna cave in like that. So this all makes sense if you think about it that way. This is also commonly referred to as knee valgus or knock knees, but again, try to do your best to understand how all of this works, because this definitely could pop up on your test just like that person who's squatting and leaning too far forward. Next up, we have the push assessment, and this assesses stabilization of the scapulothoracic joint and core control. And this test can be done kneeling. It can also be done in regular push-up position. This push assessment right here is not a test of how many push-ups you can do, though that is coming up soon as well. This push assessment is really just looking at how effective these muscles back here are at doing their job. Next up, we have the pull assessment, and this is to assess movement quality and muscle imbalances. Basically, you just have your client pulling a very light cable. You could even use a band for this one as well. So with the pull assessment and the push assessment, there aren't an exact number of reps that you should be doing with your client. It's really just enough reps for you to assess their movement patterns. Here's something that ACE is likely to ask you on, and in fairness, you do see a lot of this in the real world as a trainer. So what is overactive if the shoulder is elevated and the head is too far forward during this pull assessment? And I'm going to give you some options as to what the overactive muscles are. Are they A, the lower traps and the lats, B, the levator scapula and the cervical spine extensors, C, the rhomboids and the pecs, or D, the upper traps and rhomboids? And I'm just going to be back here hanging with my pups for a few seconds while you guys are thinking about the best answer to that question. If you chose B, the levator scapula and cervical spine extensors, you were correct. Those were the two most overactive muscles if you have a person doing this. So the lower traps in this situation would actually be underactive. People who have their shoulders kind of hiked up towards their ears all the time, they tend to be much more dominant with their upper traps rather than the lower or mid traps. The lats actually could be a little bit overactive, but again, this part kind of makes it so that that answer can't be right. The pecs would be overactive in this whole situation most likely, but the rhomboids would definitely be kind of overstretched, so that wouldn't be a great answer there. And the upper traps very likely would be too overactive on this person, but the rhomboids, well, they wouldn't be able to do their job with this person too well at all, because everything is kind of hiked up and a little too far forward. So the best answer, even though some of these other answers could kind of make sense, is this one right here, B. And the biggest hint here is the levator scapula, Well, what does the levator scapula do? It elevates your scapula. So people whose shoulders are just all up here all the time, well, their levator scapula is definitely going to be overactive. Like we said, the upper traps would be as well. So yeah, a little bit of a tricky question here, but very similar to what ACE is going to throw at you. Now, like I mentioned in the part 1 video, if you know basic muscle functions, well, then that last question probably wasn't too hard for you. If you guys want me to make a video about basic muscle functions and locations, let me know down below in a video. Again, the only reason I haven't done that already is because there are lots of other good videos covering that material here on YouTube. But if you guys want me to tackle it as well, if enough of you ask for it, yeah, I'll make it, so let me know. Okay, back to assessments now. Now we're checking out the rotation assessment, and basically here you are looking at range of motion in the thoracic spine as a client rotates. So you can see Alexis is kind of holding a dowel like this, and as she's rotating towards her left, this is as far as her thoracic spine, which is her upper mid-back. That's as far as that part of her body allows her to go. And basically we would just do a few repetitions in each direction just to see her thoracic mobility. Now we're going to talk about some muscular endurance tests. Basically, don't perform these if clients have orthopedic issues that would affect the test or cause them pain or discomfort. If a client does have pain, refer them out to a doctor. So in the max push-up assessment, you're going to have your client do as many push-ups as possible. Men perform full push-ups and women perform kneeling push-ups. And this assessment is over when they can no longer perform more reps or they do 2 reps with poor form. You have the max squat assessment, and this is the muscular endurance version. And basically it's the same thing we just did with the push-ups, except now you're having your client do as many squats as they can with good form. And if your client can't squat with good form, then don't have them do this assessment. Also, let's say I have a client doing this assessment and they're no longer getting adequate depth, just like this lady is right here. Well, then this assessment would be over. Now, with the push-up assessment and the squat assessment and a whole bunch of the other assessments, there are tables that would tell you how a client is scoring here. That being said, definitely don't memorize anything on any of those tables for the test. For example, if I was able to do over 45 bodyweight squats as a 32-year-old male, that would put me into the excellent category. Again, I don't need to know that for the test. I just need to understand these assessments and kind of have a general idea of what they look like. Next up, we have some strength assessments, and the 2 that ACE recommends, possibly depending on the client, would be the bench press and the squat. Again, avoid these with clients who have orthopedic issues, hypertension, or vascular disease. And to be honest with you guys, when in doubt, don't do these assessments with people. Also, don't have clients do the Valsalva maneuver. The Valsalva maneuver is basically where you breathe out strongly through your mouth while holding your nose tightly closed. This creates a forceful strain that can trigger your heart to react and go back to normal rhythm. So make sure clients are not doing this when you're lifting with them or if you're doing an assessment with them. Anyway, for the max squat and bench press, I'm going to oversimplify this whole process, but basically you want to start both of those 2 things off with 10 easy reps or a warm-up set. From there, you're going to estimate a 3 to 5 rep max based on the warm-up set effort displayed. Once you have the client in that 3 to 5 rep max range, then you're going to add an additional 5 to 10% of weight until 1 rep max is found. And of course, this is going to take multiple sets, and you're going to want to give breaks in between those sets as well. That being said, you don't have that many sets to figure this out because obviously the client will fatigue, and then you can't really figure out 1 rep max from there. And again, this is a little bit of an oversimplification. If you were going to do this with an actual client, I would definitely recommend going back and reading about it in the book, but this should get you by for the test. There's also a vertical jump test, and this assesses vertical jump height, duh, and it's useful with athletes who will be jumping. Also, duh. In fact, I would say this one is pretty much only useful for athletes, so keep that in mind. Next up, we have the T-test, and that is a speed, agility, and quickness drill. And basically, it assesses multi-directional movement ability. Make sure you know that, because if this test is going to come up in a question, they're probably going to mention this multi-directional little bit right here. And basically, as you can see here, we have 4 different cones set up. and you'll be sprinting between those. So you are timing how long it takes your clients to get between these cones. Next up, we're talking about nutrition, and there are a few things that you need to know here for sure. First things first, your scope of practice. So we are personal trainers, not dietitians. We don't develop meal plans for clients, and we don't do medical nutrition therapy. That being said, we can do things like to help our clients understand food labels, what certain nutrients do in the body, etc. We can, however, use the dietary guidelines developed by the government and the recommendations from myplate.gov. If there is a question about what you can legally do as a personal trainer nutrition-wise, the answer most often will have to do with the US Dietary Guidelines or myplate.gov. NASM and ACE are both very squeamish giving you advice on what to do dietary-wise with clients. So it's safe to assume that almost everything is out of your scope of practice in their eyes. It won't be uncommon for a question to come up where the best thing for you to do would be to refer the client to a registered dietitian. For example, if a client has diabetes and they want to lose weight, even if it's something that you could help them with, the correct thing to do would be to refer them to a dietitian. In fact, if any client with health issues needs nutritional guidance, the correct thing to do is to refer them to another health professional, either a doctor or a dietitian, depending on the issue. So in recap, as a trainer, all you can really do is a little bit of nutrition education with your clients. You can help educate clients on hydration and nutrition, but you don't have much power beyond that. One thing I quickly mentioned back there was food labels. On the test, you could be given a food label, and then you have to figure out some information based on that label. And to be able to accurately do that, you do need to memorize a few pieces of information. You have to memorize that 1 gram of protein equals 4 calories, 1 gram of carbohydrate is also 4 calories, and 1 gram of fat is 9 calories. Memorizing this information right here and reading food label questions very carefully should allow you to do very well on that part of the test. For example, let's look at this box of Cheez-Its. How many calories would I get from protein in 1 cup of this product? Okay, so first things first, we gotta go down to protein, and we see 2 grams right here. We can see that for every 1 gram of protein we have, we get 4 calories. So 2 grams right here times 4 equals 8. And most likely 8 would be one of the choices in an A, B, C, D multiple choice exam, except 8 is not the right answer. The reason it's not the right answer is because I'm asking for 1 cup of this product, and this serving size is only half a cup. So don't be tricked by that. The answer is actually 16. Again, we get that by doing 2 times 4 because there's 4 calories in every gram of protein, and then we have to multiply the serving size by 2 to get a full cup. So the answer would be 16. So really make sure you understand everything I just did there, because ACE is absolutely going to throw a few questions like this at you on the big exam. And a few more little bits of information here. ACE advises an everything in moderation approach that is high in veggies and to some extent fruit. There's a chart on page 169 that shows recommended dietary intakes for things like protein, fats, and carbs. Don't memorize it, but get a general understanding of what people should be consuming. Another little tidbit here that could be super important, there is 3,500 calories in a pound of fat, and a 500 calorie daily deficit would get you to roughly a pound of fat loss every week. So just keep all of that in mind if ACE asks you a question on calorie deficits or fat loss. Something that is probably worth memorizing here are fluid intakes. So before exercise, at least 4 hours before exercise, ACE recommends 5 to 7 milliliters of water for an average-sized person. During exercise, monitor sweat loss and replenish fluid and sodium, potassium, and carbs. After exercise, drink 1.5 liters per kilogram of body weight loss due to sweat, and consume sodium. ACE is very big on sodium consumption around sweat or exercise, so always keep that in mind if they ask you a question about it. So in the last part of this video, I'll be jumping all over the damn place, and we'll be talking about just a bunch of random stuff that's worth knowing, and this could be stuff that I might have missed in previous sections, or it might just be something totally random that ACE could throw at you on the big test. So we're just talking about nutrition, and one diet that ACE talks about a fair amount in the text is the DASH diet, which includes foods that are rich in potassium, calcium, and magnesium. And this diet limits foods that are high in sodium, saturated fat, and added sugars. And the whole point of this diet is to help lower a person's blood pressure. So if ACE asks you a question about a diet that would lower blood pressure, the answer is the DASH diet. Okay, so up next we're talking about BMI or body mass index, and BMI is an interesting one. We have two different formulas to figure BMI out, and before we go any further with BMI, just understand that BMI is purely about height and weight. BMI has nothing to do with body fat. So on the test, you may have to calculate someone's BMI, and there are two different formulas that you could use to figure that out. So you have the first one right here, which is kilograms, height in meters squared, and then you have this other one, which there's a conversion factor of 703. And again, the formulas are both right here. It doesn't really matter which one you use. Both are going to get you the right answer. Now, should you memorize these equations? That's always an interesting question. I don't think you have to. There's a very good chance that ACE will give you one of these two formulas to use on the exam. That being said, they're not really all that complicated. So me personally, I would just memorize them. But if you feel like memorizing either of these two formulas is going to take up too many mental resources as you're studying, then I wouldn't memorize them. The only thing I would memorize in that case is that a BMI over 25 means you're overweight and 1 over 30 means you're obese. And if we scroll back to the very beginning of this video, a BMI greater or equal to 30, yeah, it means you're obese, and that is a risk factor. So again, that part at the very least is worth memorizing. Now, unlike BMI, which had nothing to do with body fat, bioelectrical impedance, or BIA, has everything to do with body fat. If you have a scale that's telling you your body fat percentage, or if you have one of those little handheld things, both of those two things are using a technology called bioelectrical impedance. And basically they determine your body composition based on the rate at which an electrical current travels through the body. Body fat, or adipose tissue, causes greater resistance or impedance than fat-free mass or muscle mass and bone and things like that, and it slows the rate at which the current travels. Bioelectrical impedance does require specific testing arrangements though. For example, if I am dehydrated and I do a BIA test, I am going to show up as fatter than I actually am because water conducts electricity, and I will have less water in my body to conduct that electricity. However, if I'm overhydrated before I do a BIA test, I'm going to come up as leaner than I actually am because, again, water conducts electricity and I now have extra water in my body. So the tests here are only somewhat reliable, but because they're simple, they are used in lots of different fitness settings. Anyway, moving on here, the nervous system has two main components, the somatic nervous system and the autonomous nervous system. The somatic nervous system is mostly under our control. It mostly involves skeletal muscles and things like that. Again, skeletal muscles being something like my biceps, something that I have total control over, versus smooth muscles, which many of them are internal to our bodies and we don't have direct control over them. The autonomous nervous system is automatic, as the name would imply, meaning it is not under our control. And if we take that a little bit further, the autonomous nervous system is split into two parts. The sympathetic nervous system, which controls our fight and flight response, and the parasympathetic nervous system, which has to do with resting and digesting. Next up, we have muscle fibers. Type 1 muscle fibers are slow twitch, meaning they have better endurance but produce less power. Then we have type 2 muscle fibers, and those are fast twitch, and they generate more power but they have less endurance. That's supposed to say endurance capabilities. So type 2 muscle fibers are fast twitch. They are better at generating power, but they have less endurance capabilities. I will fix that when you guys potentially download this guide and use it on your own. This was something I saw pop up a few times in the practice exams, and I saw it on my official exam as well, and it's kind of a doofy question, but yeah, anyways, what is the primary purpose of the ACE Personal Trainer Certification Program? And the answer is to protect the public from harm. And I included this one because, like I said, I did have this actually pop up on my official exam, but I also think this question gives you an idea of how ACE thinks. They see us as very noble and protectors of the public, so it's just good to have that understanding going into this exam. On a somewhat related note, when we're talking about scope of practice, the least aggressive answer will usually be the correct one. We have an example here. You have an injured tennis player client. What should you do? And this was an actual question during the practice test. So if you've already gone through the practice test, you've probably kind of seen this, but that was by far the least aggressive approach given the other options that were there. And again, I think it just shows that when we're talking about scope of practice, the least aggressive answer will usually be the correct one in ACE's eyes. We talked about all this stuff a fair amount in the first video, but I think it's good to touch base on this stuff again. Static stretching would be where you're holding a stretch for roughly 30 seconds. So if I'm doing this stretch and just holding it for 30 seconds, that is a static stretch. A dynamic stretch would be a movement pattern designed to mimic the workout. So if I come back here and I do a few body weight squats, that would be dynamic because it's preparing me for the workout that is about to happen. Lastly, you have ballistic stretching, which is repeated bouncing, swinging, anything really aggressive and kind of spastic to stretch a muscle group. That'd be ballistic stretching, and you want to avoid this one. If something questionable comes up in a session, like your client sharing too much information about their divorce, the correct thing to do would be to redirect the focus of the conversation back to the workout. Pretty self-explanatory here, but the correct thing to do in almost any situation like this would be to redirect, so keep that in mind. Also keep in mind that goals need to be positive. In fact, pretty much everything to ACE needs to be positive. Cueing also needs to be positive, or at the very least, not negative. A few other little random facts here. Dyspnea is difficult or labored breathing, syncope is fainting, and orthopnea is the sensation of breathlessness in a recumbent position relieved by sitting or standing. I don't know why, but when I was studying for ACE, these three things very commonly came up, so it's probably worth discussing all three, at least very briefly here. I think this is just generally good to know in general, and this could come up in some form or another on your exam, but remember, breakfast, lunch, and dinner, it's a good trick to remembering how many vertebrae you have in each of these areas. So you have 7 cervical vertebrae and 7, think 7 a.m., that's breakfast. Next we have the thoracic, you have 12 thoracic vertebrae. Again, that's lunch, so think like 12 p.m. lunch. And then dinner would be the lumbar, you have 5 lumbar vertebrae. And again, think like 5 p.m., and that would be the lumbar. You also have 5 fused sacral vertebrae here, and I don't really have a good way to remember that, so you'll just have to kind of remember that. But those ones, again, they're fused together, unlike these other ones in these other areas here. And then, of course, at the very bottom, you also have the coccyx. Next up, we have the double progression training protocol, and just like some of the assessments that we went over today, we need to kind of talk about this a little bit, but we don't need to go into every single small little detail. So let's say I'm able to do 10 reps of an exercise at 100 pounds. Before increasing the weight here, this 100 pounds, what I want to be able to do is 15 reps. So essentially, I'm just going to keep kind of grinding away at this 100 pounds until I can do 15 reps at that 100 pounds. Once I can do 15 reps at 100 pounds, I'm going to increase the weight by 5% up to 105, and then I'm going to go back to doing 10 reps again. And basically you just keep repeating this cycle and adding reps and adding weights, and that is how this double progression training protocol works. Again, nothing you need to memorize, but something that's probably good to understand. Back to the talk test. We actually talked about the talk test quite a bit in the first video in this series, and really the talk test is a diagnostic tool. At an intensity level above VT1, ventilatory threshold 1, but below VT2, an exerciser will still be able to speak, but not comfortably. VT2 represents the point at which high-intensity exercise can no longer be sustained due to the accumulation of lactic acid. And we're really only going to talk about this a very small amount, but when it comes to business structure, I definitely think there are 2 things that you should understand in particular. One, you have a sole proprietorship, which is a business that is owned by an individual, and you have no protection for the owner. What ACE is likely to prefer over sole proprietorship is an LLC a limited liability corporation, and rightfully so, because this provides protection to the business owner. LLCs are relatively simple to set up compared to something like a small corporation. Next up, we have independent contractors, and you're an independent contractor if you are a self-employed person or entity contracted to perform work or provide services to another entity as a non-employee. As a result, independent contractors must pay their own Social Security and Medicare taxes. If I'm a personal trainer renting space in a gym and I'm working for myself, no one's giving me hours or anything like that, basically, I'm just an independent contractor. I am my own boss, and I just happen to be renting space. On the other end of the spectrum, we have employees, and you have employees when the business has the right to direct and control the work performed by the worker. This includes hours worked, uniforms, etc. The list goes on. Now, there are many things that I didn't cover in this guide that could appear on the test. For instance, I really didn't get too into special populations or those last few chapters of the textbook. If you understand everything that we covered in these 2 videos and then read those chapters over, you should be good. I'm not directly pulling as much from those chapters for these videos or guide because ACE doesn't seem to pull from them as much on their test. This guide is really just meant to teach you some of the more important things that ACE wants you to understand for the test. Like we've said before, I'll say it one last time, make sure to read over the material in the ACE textbook. Also use the videos and quizzes to help you study the material. The ACE quizzes are a good diagnostic tool. As in, if you're doing really well on those ACE practice quizzes and you use these videos and materials to help study, you should be fine. My advice is to give yourself at least a month or 2 to go over all of ACE's material and these guides. Try to just do 1 to 2 hours of studying each day. You'll always hear stories of people who pass that big exam by only studying for 48 hours leading up to it, or maybe they give themselves a week or so. This will probably only work for a very small percentage of you, so I can't recommend it. Give yourself at least 3 to 4 weeks to prepare. Even longer than that is better. I want to wish all of you luck on that big exam. Not that you'll need it. Go crush that thing and maybe we'll be working side by side at some point. Who knows, crazier things have happened. Anyways, if you guys have any questions or comments on anything, please leave those down below and I will respond to you. And if you haven't already, please consider liking the video and subscribing to the channel because it does help the channel to grow, which does allow me to create more free content for all of you. Thanks for watching, everyone, and until next time, stay Sorta Healthy.